Well, hello, and welcome to my pediatric case study on a gastrointestinal disorder. So, a 4-year-old is brought to the clinic with a 3-day history of vomiting, a 2-day history of diarrhea, and no fever. So, the RN will first want to gather the subjective history. So, again, think of this as an NCLEX question or an exam question. And what are you thinking about? What are you thinking that this possibly might be? Think about the age group. Whenever an age is given to you in a question, that will potentially help you figure out what's going on because there's certain disorders that are more common in certain age groups. So, the subjective history, the patient is only urinating about 2 times per day. So think decreased urinary output, think dehydration with that. Taking only sips of water, no food. Again, more signs that this child might be dehydrated. Vomiting about 3 times a day, which is a lot. And large amounts of watery brown stools, but there's no blood in the stool, which is good. But again, it looks like the child is losing a lot of fluids from that vomiting and diarrhea, and they're not replacing it with enough fluid. Objective data. Child is 21 kilograms, hyperactive bowel sounds. So why would the bowel sounds be hyperactive? Well, think of what diarrhea is. Diarrhea is moving the stool through the bowels at a fast pace. And the bowel sounds are the peristalsis, or moving the stool. So it's moving it really fast for some reason. So you're going to hear a lot of gurgling when you listen with your stethoscope. The child is found to be dehydrated, and the signs of that, the heart rate is elevated at 110, decreased turgor, so the skin is not elastic. There's not enough water in the body. The lips are dry and the eyes appear sunken. When the RN does the examination, it is found that the abdomen is slightly tender to deep palpation on the lower quadrants. So, this may change what you're thinking the possible diagnosis is. Also, there is no rebound tenderness. So we know that we see rebound tenderness with things like appendicitis, and there's no rebound tenderness, which is good. So the provider sees the child and diagnoses the child with gastroenteritis. Some lay people may refer to this as the stomach flu, where you see a lot of vomiting and diarrhea. It's not caused by the influenza virus, but somehow it got that name of the flu. So some people think when they're getting a flu vaccine or an influenza vaccine every year that they're protecting themselves against the stomach flu. So you need to be very clear with your patients why they're getting an influenza vaccine. That's to prevent the coughing, fever, feels like you got run over by a truck kind of flu. The gastroenteritis, or stomach flu that some may call it, causes vomiting, diarrhea, sometimes a low-grade fever with that. So it is a virus that causes gastroenteritis, and the management is rehydration because it can lead, especially in pediatrics, to pretty significant dehydration. We need to make sure that we rehydrate the child. So this can either be done in an oral form or IV, depending on how sick the child is, depending if their vomiting is continuing. You may be able to do oral replacement therapy with just small sips of an electrolyte replacement like a Pedialyte very frequently and kind of trick the body into accepting those fluids. Or if the child is sick enough that the vomiting just is continuing, the child may need to be hospitalized for IV fluids. It could also give an anti-nausea medication that you learned about last semester. They may be able to give that if the child is hospitalized as well. Another recommendation is if the child vomits, to not offer the child anything by mouth for at least an hour. And then once the child has had a chance to rest their stomach, then you offer small sips of that electrolyte replacement fluid. Don't offer food. You want to start with clear fluids if oral replacement therapy is how this child will be managed. And then you'll slowly reintroduce, once the vomiting stops, you'll slowly introduce crackers, bland foods until you're up to a full diet. Now the pens up for this case study, one of them is that we no longer recommend the brat diet, bananas, rice, applesauce, and toast. That used to be a recommendation that was given to any child that had vomiting and diarrhea. And it was found that the brat diet is very low in nutrients and is really not needed. Once the child is tolerating solids, they can go back to their full diet. Of course, avoiding things that have a tendency to make the stomach a little bit more sensitive, like spicy foods, you want to stay away from that. But they can go up to their full diet once they're tolerating solids. So no brat diet any longer. So this child is significantly dehydrated, so we are going to admit the child to the hospital for IV fluids. So how do you know how many IV fluids, how much IV fluids to give a child? Well, remember the formula, or the calculation that you learned about in the last module, but it's 100 milliliters per kilogram of body weight for the first 10 kilos, then 50 milliliters per kilogram of body weight for the next 10 kilograms, and then 20 milliliters per kilogram of body weight for the remainder in IV fluid replacement. So this child weighs 21 kilograms. So as an example, 100 milliliters times 10 gives you 1,000 milliliters. And then 50 milliliters for the next 10 is 500 milliliters. So we're already up to 1,500 milliliters per day we're going to replace. And the child is 21 kilograms. We have one more. So 20 milliliters per kilogram of body weight for the remainder. So that's just one. So an extra 20 milliliters. So 1,000 plus 500 plus 20 is 1,520 milliliters every 24 hours to replace the fluids that are lost. In order to find out how to set your IV pump, IV fluids are set in an IV pump in the rate of milliliters per hour. So you set the IV pump to milliliters per hour. You don't set it up for milliliters per day, as that 1520 would indicate. So how are you going to get that number? You just divide by 24. So 1520 divided by 24 equals 63 milliliters per hour of IV fluids. So the child gets rehydrated in the hospital and is feeling much better very fast. So what discharge instructions are we going to give to the parents of a child with gastroenteritis or vomiting and diarrhea? We want to tell the family to offer small amounts of oral rehydration solution frequently. When the vomiting is stopped, then you reintroduce those solids slowly. So since this child has been hospitalized, the vomiting has stopped, but sometimes vomiting can recur. We want to give parents that anticipatory information in case the vomiting starts again. We want to tell them to avoid high carbohydrate fluids like Kool-Aid and juice. We want to tell them to monitor the child's urine output carefully. They don't have to measure it usually, but how many times per day the child is urinating is sufficient. We do want to discourage milk products because that may worsen the diarrhea. Usually the vomiting is the first sign of a gastroenteral infection because the germs are usually spread through the fecal oral route. So some child will get contaminated on their hands with the virus and will touch their mouth. It goes to the upper GI tract in the stomach, and the body recognizes this germ and says, we got to get rid of this. So it comes up as vomiting. Then, if the germs are strong enough, they travel down to the lower GI tract and the body says, hey, we got to get rid of this, and it comes out as diarrhea. So the diarrhea can actually last up to 2 weeks, and you can feed through diarrhea, meaning, again, you don't have to only offer clear liquids or the brat diet. You can offer the child's regular diet if there's just diarrhea that continues, because it may last for a little bit of time. The child can be active as tolerated. There's no need for bed rest. And we do want to assess skin integrity, especially in the newborns and any babies that are still in diapers, because that frequent stool is sitting on the buttock area. It can be very caustic to the skin and can burn. So it can decrease that skin integrity in that perianal region as well pretty quickly. So you want to watch out for that and treat any diaper rash. And that is it. Thank you.